So you have a 58-year-old male who came from surgery, that is a post coronary artery bypass graft. This is the second day in the ICU, that is post-op day 1. The patient obviously had a history of ischemic heart disease with a reduced ejection fraction of around 35%. He underwent a 3-vessel CABG, which was uneventful, and the patient was just put on ventilator and was planned to wean slowly and get extubated the next day because the ejection fraction was low. The next day morning, the vitals are heart rate is 96, the BP is stable with a MAP of around 77, the CVP is 14. The urine output has been 20 ml per hour over the last 3 hours. Lactate is 4 millimoles per liter. There is mild congestion in the chest x-ray. Now, but with this scenario, in the morning rounds, there is a little debate going on what to do about this CVP. Now, the surgeon's interpretation is like this. He thinks that the CVP is elevated, which means that the patient is fluid overloaded. So he plans to hold out fluids, restrict fluid intake, and give a low dose of furosemide. He believes that post-op the patient has developed this condition because slightly higher fluid was given the day before. The interpretation of the intensivist is a little different. He says no, CVP is meaningless, that 14 doesn't mean anything. I am more focused on the lessening urine output and the lactate that's rising. I believe the ventricular function is not good. So I would rather start a inotrope and not a diuretic. So clearly there is a very different interpretation of the same CVP value as you can see over here. So we will come to this case later on. Let's first discuss a little bit about the CVP. Now, CVP, it measures the pressure in the superior vena cava using a catheter which is placed through the jugular or the subclavian vein. Now, CVP is indirect measure of the right atrial pressure and reflects the amount of blood returning to the heart. This is what we are trying to find out. The amount of blood that is returning to the heart. A preload. How do we measure it? The transducer, that is the measuring device, must be zeroed at the phlebostatic axis, that is midpoint of the right atrium, for accuracy. Measurement must be done at end expiration when the chest pressures are lowest. Try to record the value at the base of the C wave on the CVP waveform. This is a very important concept that you must understand. You measure it at the end expiration and at the base of the C wave. In spontaneous breathing patients, not on ventilator, the number of monitor is usually reliable even with irregular breathing. Now, why CVP has lost its popularity? Why this intensivist was so keen on totally ignoring the CVP value? The research has shown that CVP is not a good predictor of fluid responsiveness, which means that if you give fluid, whether it will increase the cardiac output of the patient that cannot be determined by the CVP value. Meta-analysis have actually confirmed this. There have been very large reviews which have corroborated the individual studies, and combining them also we find the same thing, that CVP is not a good predictor. Now CVP waveform has some extra clues. The shape, that is the tracing, the waveform can help diagnose certain heart and lung conditions such as tricuspid regurgitation. In this diagram you can see how the tracing has changed, or cardiac tamponade. In this you can see how the CVP has changed because of the tamponade. Now the Guyton's model. What is this venous return? Venous return is the amount of blood returning to the right atrium each minute. This has to be equal to the cardiac output, because the blood that is coming back has to go out also. If there is any mismatch, we will get either blood in the lungs or edema of the peripheries. VR depends on the difference between the two pressures. What are these pressures? The mean systemic filling pressure. This is a theoretical pressure which is in the small veins, and it depends on how much blood is in the system and how tight the veins are. And last but not the least, the CVP, of course, which is the pressure in the right atrium. So this pressure difference determines the flow. So the VR gradient is the mean systemic pressure minus the CVP. If you increase the mean systemic pressure, how do you do that? You give fluids, make the veins more tense, or you can use vasopressors, make them constricted and tense again. Both of these conditions will increase your venous return. The heart pulls the blood in by keeping the CVP low. However, a weak heart which is unable to pump properly cannot keep the CVP low. It increases the CVP, reducing the pressure gradient, thus decreasing both the venous return and the cardiac output. So here you can see the Frank-Starling curve and the Guyton venous return curves being superimposed. You can see here, this is the cardiac contraction curve. Here you give fluids and the CVP changes from here till here. So this pushes the venous return curve from here till here, because by giving the fluid we have increased the mean systemic filling pressure. So this elevation resulted in an improvement in the cardiac output, which was previously here has increased. So this patient is fluid responsive. However, in this case, the fluid was given, the mean systemic pressure increased. However, the curve here was more on the flatter side, so you did not find any improvement. So it's not the absolute CVP value which is almost same over here. However, it's the patient's contractility which is again determining. So that is why you can understand that why CVP is not very helpful, especially if you are using just a single random value to get fluid responsiveness. Here the patient is not fluid responsive, there is not a much increase in cardiac output. And in this case, by using inotropes, you have improved the contractility, thereby reduced the venous congestion. the CVP has reduced. Previously the CVP was higher, and as the contractility improved, your venous return improved and the CVP has come down. So this is how you can treat these type of patients. CVP as downstream pressure for organs. The organ blood flow depends on the mean arterial pressure or the mean perfusion pressure, which is calculated as the mean arterial pressure minus the CVP. Mean perfusion pressure tells us how much pressure is pushing through these organs. If the CVP rises, the mean perfusion pressure will drop, meaning less blood flow to the organs. So the clinical relevance in critically ill patients, keeping the organ perfused, that is the perfusion pressure adequate maintenance, is vital for the organ support. High CVP can mean that organs, especially the kidney and the liver, are not getting enough blood flow, even if the map looks normal. So you may have a normal map, but if your CVP is very high, your perfusion pressures are low. In heart failure, high CVP is linked to poor liver function and problems with tiny blood vessels or the microcirculations. In sepsis, you have high CVP, not just low MAP, which can cause venous congestion, blood backs up, pressure rises, and same thing we find in the kidneys. This situation increases the risk of acute kidney injury. So the key point here is a high CVP is associated with organ dysfunction, but we can't always say for sure when it's high. Because the problem or is just a marker of how sick the patient is. Means, is it really a thing that we need to treat, or it is just a sign that the patient is sick? Now CVP as the reflection of right ventricular filling pressure. Under normal conditions, the transmural CVP closely reflects the filling pressure of the right ventricle during the relaxation phase or the diastole. The transmural means the pressure inside the heart chamber minus the pressure outside, that is the chest wall or the pleural pressure. Effect of mechanical ventilation. When a patient is on ventilator, the positive pressure in the chest can artificially increase the CVP readings. To estimate the real transmural CVP during the mechanical ventilation, adjust for the intrathoracic pressure using this particular formula. So the CVP is measured CVP, that is the transmural CVP is measured CVP minus change in CVP between the peak inspiratory and end expiratory multiplied by P divided by P plat. So this will give you the transmural CVP. So how do you measure it? Again, the transmural CVP is measured CVP minus the change in the CVP between the peak inspiration and end expiration. You will get two values of CVP during inspiration and expiration. You get that difference multiplied with P divided by the P plat. In simple terms, remember that the ventilator pressures can change CVP look higher than it truly is. This is just a simplistic thing. If you don't want to do the calculations, you can just remember this, that if you have a higher pressure in the thoracic cavity, it will obviously go on and increase the measured pressure a little bit. To find the exact pressure, you have to do this calculation. Now, high transmural CVP can indicate a right ventricle that is over distended, a right ventricle which is stiff, or both. Both can cause blood to back up in the veins and reduce the venous return. In ventilated ICU patients, high CVP doesn't always mean heart failure or fluid overload. The ventilator pressures can also be the reason. So there have been a lot of research, and the findings are that in mechanically ventilated patients and those with true right ventricular dysfunction, they always have a higher CVP. CVP is more accurate in detecting combined right ventricular dysfunction and venous congestion, with a cutoff of 10 being suggestive. So if the CVP value is more than 10 millimeters of mercury, then there is a chance that there is right ventricular dysfunction and venous congestion. So there is a gray zone, that is the zone between 9 and 12, where it is harder to interpret the CVP values. If it is less, then unlikely there is any venous congestion or right ventricular dysfunction, or if it is more than 12 also, there is no problem. But if it is between this 9 to 12 value, which is usually found in many cases, it is difficult to interpret where the patient is exactly. Practical uses of CVP in hemodynamic monitoring: extreme values can guide your fluid therapy definitively. A very low CVP would definitely suggest again a low preload, suggesting the need for fluids. But these are extreme of values where you hardly have any doubt. Again, the cutoffs are not very clear, but obviously something which you will know from your practice. Very high CVP indicates a risk of fluid overload. Giving more fluids may be harmful. So quite clearly, if you are having a very high CVP, there is definitely no need of fluids there. These clear situations are found in very rare patients, that is in 1 out of 3 patients only. That is the CVP is less than 2, so you are giving fluid, or if it is more than 14 or something, where you are warding against a fluid. Now the gray zone and its limitations: most patients unfortunately are in this gray zone. That is, they are not very high, not very low, making it very hard to decide on the fluids. And again, subjective interpretations, as we saw by both the intensivist and the cardiothoracic surgeon. Absolute CVP values does not reliably tell who will respond to fluid. So this is quite established right now, but it doesn't really mean that it is useless for any other purpose, because fluid responsiveness is not the only thing that we use hemodynamic monitoring for. Changes in the CVP during passive leg rising or breathing cycle can also not consistently be reliable for the same purposes. PLR and CVP: if the CVP increases by more than 2 during PLR, it may help predict fluid responsiveness when combined with the pulse pressure variation. So for example, during PLR the CVP rises by 3 and the pulse pressure also changes. This supports the fluid responsiveness. CVP has downstream pressure, that is the organ impact. High CVP impairs the venous return and is linked with worse organ outcomes. So reducing the CVP in those cases is vital and may benefit some patients like those with ARDS. How do you manage congestion? If the patient shows signs of congestion, that is peripheral congestion, that is swollen limbs, or pulmonary congestion where you have crackles, even if the heart is still depends on the preload, be cautious about giving more fluids in these cases. Reevaluate early. Regarding right ventricular failure, in right ventricular failure the CVP will be high. Giving more fluids is not at all helpful there. High CVP with right ventricular dysfunction increases the risk of death. So the current best practice is: don't use CVP alone to guide fluids. Interpret in combination with other signs, clinical exams, ultrasound, dynamic maneuvers like this. Focus on trends, which is important. changes in CVP rather than single values is important. Use CVP as a marker of venous congestion and to avoid decongestive strategies, especially in conditions like heart failure, ARDS, and right ventricular dysfunction, to guide decongestive therapies. And to summarize how to use CVP, when not to use is it should not be used to predict fluid responsiveness, the preload dependency, or to hemodynamic optimization, like that. What you should use for is as a downstream pressure for organ perfusion, an indicator of right ventricular function, and as a safety variable. Thank you for your patience.